Hello, everyone, and welcome to this session, this HSG Africa session titled Conceptualizing Urban Health Systems and Their Governance. So the thematic focus of our session today will be under urbanization and health systems, and I'll be giving an introduction before I call the speakers for. So with me, we have four session speakers, panelists who will be making presentations, and we'll be ready to take questions and answers from the floor. But before I make the introduction, I would like to quickly introduce the session for what we are going to be talking about. So we all know that rapid urbanization is transforming a lot low middle income countries and bringing about immense demographic shifts with respect to disease burden and structural determinants of health. But most of those determinants actually sit outside the traditional remit of health system. And it means that everyone has critical roles to play. But linking the urbanization management of these diverse stakeholders also presents an opportunity for the health systems to respond to the challenges. And I think our speakers are going to be speaking immensely to how the health systems can contribute to the response we have to what urbanization is causing. But I mean, there are also significant changes posed in terms of health systems governance and governance in general. So the question is, how should we lead this response, and who should lead this response, and how should we organize it? And we know that given the rapid urbanization in Africa and low middle income countries in general, this is it's an ever important and increasingly important need that needs to be talked about. So the purpose of our session now is to bring together learnings and reflections on urban health systems and their governance in the context of urbanization in Africa and in Asia, specifically and generally in low, middle, and income countries. So in other words, we are seeking through this session to distill the context-specific and sensitive lessons that our speakers have gained from policy and decision makers on health systems governance in both formal and informal settings. And we are also going to try to identify thematic areas that will benefit from this cross-national comparative research that are going to be presented. So lastly, we are going to, we hope that one of the outputs is also going to contribute to ongoing works and dialogue among health policy and systems researchers and policymakers in terms of health systems governance in urban LMIC settings. So having said that, we are going to be having four presenters present. Each presentation will be immediately followed by a few minutes of question and answer from the floor. So the first presenter will be Ifeanyiwa Arinze. Ifeanyiwa is she's currently pursuing her PhD in health economics and management. She's a lecturer with the University of Nigeria, Nsukka, Enugu campus, and she's very vast with health policy systems research with the health policy research group in that same institute. Ifeanyiwa is interested in health policy and systems research, health economics, and health information system. And she has also been involved in many internationally funded research. But right now, she's currently working on a DFID-funded research on community-led responses for improving urban health systems for the urban poor. Her research is basically based in Nigeria, and she will spend the next couple of minutes telling us about stakeholders' perspectives on strategies for strengthening urban health systems towards reducing disease burden among the urban poor in Nigeria. So Ifeanyiwa takes the floor now for her presentation.
So good day all. I'll be standing on all existing protocol to share a study on stakeholders' perspective on strategies for strengthening urban health system towards reducing the disease burden amongst the urban poor in Nigeria. Presenting on behalf of the team, I am Ifeanyiwa Arinze of the University of Nigeria in Nsukka, Enugu campus. So urbanization is increasing rapidly in low and middle income countries like Nigeria in response to disparities between urban and rural settings. Currently, 55% of the world's population is living in the urban area, and it is projected that 68% of the world's population will be living in the urban area by 2050. Nigeria has been projected as one of the 3 countries that will account for 37% of this increase in global urban population by that 2050. By 2019, about 40.1% of Nigerians' population were poor, while 18% of urban population had a poverty gap index of 4.5%. And we know that unplanned and uncontrolled growth, which is a characteristic of urbanization, tend to increase urban health crisis. So the implications of this urban rapid urbanization in Nigeria includes that there will be deterioration of urban infrastructural facilities. There will also be deterioration of urban healthcare facility and easy spread of communicable and infectious disease. There will be a high burden on available primary health centers, and health inequalities in urban areas will grow. And as people migrate from this rural area, as a result of the increase of the cost of rent, we find that most times they move to the outskirts of the city to form small settlements. And most of these outskirts, because they are unplanned, will lack basic amenities. And as a result, they form what we call the urban slum. This, the picture beside is a typical example of an urban slum in Nigeria. So as this growing number of people migrate to urban areas in Nigeria, the adverse health impact of uncontrolled urbanization is most likely to be felt by this urban poor. And as a result, our study aims to identify and deliberate on strategies to reduce the disease burden on the urban poor in order to address and mitigate the impact of this urbanization on this group. We used an exploratory qualitative research methods involving focus group discussion. In terms of qualitative data, we collected data through document reviews from published and unpublished documents. And we had a 5 parallel group discussion with key stakeholders. It was a purposive sampling of these representatives from the communities, including private and public health service providers, informal health service providers, policymakers, politicians, and communities. So we use these key stakeholders because we wanted to have a diverse group of opinion and their perspectives on how the strategies that can address this issue. So these are the results. So in terms of the characteristics of the urban poor, we disaggregated it in terms of demographic characteristics, socioeconomic characteristics, and health-related characteristics. In terms of the demographic characteristics, we found that the urban poor were characterized with poor housing, lack of basic amenities. In terms of socioeconomic characteristics, we also found that they were associated with low income, unemployed or working in the informal sector, or low level of education or even no education at all. In terms of health-related characteristics, we found that the urban poor had a preference for accessing care through informal health service providers like the patent medicine vendors, the traditional pet attendants, and the traveling drug salesmen. As a result of this, they had a higher risk for neglected tropical disease, higher risk for malaria, TB, skin infection, HIV infection, and higher risk for childhood diarrhea, at a higher risk for non-communicable disease, respiratory disease, diabetes, hypertension. And we found also that the drivers of these health problems, in terms of demographic factors, we found that because they were living in overcrowded area, with poor ventilation, poor sanitary disposal methods, poor inadequate water supply, poor or no adequate water supply, and poor sanitation, they were affected by these health diseases. And then in terms of socio-economic factors, because of poverty, they could not access the primary health facilities. And again, because of their low level of education, they had they couldn't make an informed choice. Now, in terms of the health service related factors, some of the drivers of these health problems was that even in the even the available PHCs, there was unavailability of health workers. There was also frequent stock out of medicines, and then a relatively higher price of medicines in the PHC as against from getting medicines from the informal health service providers. Also, there was unavailability of clinical guidelines. In PHCs, we found that there was no guideline for management of non-communicable disease and communicable diseases in the PHC. As a result, these were some of the quotes that we got that informed our results. And as a result of this, we came up with strategies to address them. And we also disaggregated them in terms of health system specific strategies. And we said one of those strategies was what? Provision of comprehensive package of essential health services. Another strategy was policies and guidelines for integration of informal and formal health service providers, because we found out that health providers informal health service providers were easily more accessible to the urban poor. So we wanted to find policies that would regulate these informal health service providers. We also found that there was need for policies and guidelines for integration of health services to provide NCD, CD, and mental health services in PHCs. And then another one was the need for financial risk protection so that people can access needed care. We also found strategies to address the social determinants of health and diseases was the need for health education of the urban poor, provision of basic amenities in urban poor settings, and then need for multi-sectoral collaboration for health. In conclusion, the rapid influx of people into cosmopolitan cities and expansion of urban areas into surrounding areas necessitates urgent action, especially as the urban poor bear the brunt of its impacts. And for Nigeria to achieve universal health coverage, a multi-sectoral strategic response is required to address the health needs of the urban poor. Thank you for listening.
Yeah, okay. Thank you so much, Ifeanyiwa, for the presentation. So we'll go now to take questions. So just to inform everyone that we would like to take all questions, but we may not have the time to do so. But you can type your questions as well in the live Q&A. And in case we are unable to take it before we move to the next presenter, Ifeanyiwa will be able to answer them individually to you, so you can still get your questions answered. So, so if you have any question right now, just click let us know by a show of hands or by typing your questions in the live Q&A box. Does anyone have any question? Okay, thank you. So I think we'll be moving to the next presenter. We can take the questions that come later if any questions come from or with response to Ifeanyiwa's presentation. So the next presenter will be Sushil Baral, and he will be talking to us in the next couple of minutes on the analysis of the process of developing policy for urban healthcare provision in Nepal. Before he goes ahead, I would just quickly like to introduce Sushil. So Sushil is a Nepal citizen born in Remote Hill district of Western Nepal. Sushil has more than 25 years of professional experience in health systems, in public health policy and planning, in operational research and wider social development, particularly in developing countries context in South Asia. Over the years, Sushil has worked in a number of institutions, including government, UN agencies, DFID, academic institutions, and community-based organizations within the health and social sector. So Sushil will have the floor for the next couple of minutes to make his presentations. Sushil, you have the floor, please.
Welcome to my presentation. My topic of presentation is analysis of the process of developing policy for urban healthcare provision in Nepal. My name is Sushil Baral from Health International, Nepal. Along with other colleagues listed in the slide, let me briefly present the background of this study. The rapid and unplanned urbanization across the low-middle income countries is leading to inadequate provision of basic healthcare services, also increasing inequity in the population. In a specific context to Nepal, Nepal is the least urbanized country in South Asia. However, it has the fastest rate of urbanization, an increasing spread of infectious diseases, as well as chronic diseases, injuries, and worsening condition of environment conditions are major challenges to urban areas. The lack of effective policy framework for the urban health and continuous deprioritization of urban health matters further challenges the context. The objective and methods of the study, the objective is to identify the factors that are effectively essential for the development of the urban health policy in the context of Nepal, and to identify measures to strengthen future development process of policy, which requires multi-sectoral engagement in Nepal as well as in other settings. The methods we use is retrospective case study methods. We use qualitative semi-structured interview supported with the interview guides, and we used purposive sampling to identify the respondents. We also reviewed the relevant policies and process guides. We also used policy analysis framework in order to analyze the content, not only the content, but also the process, context, and actors. Let me take you to the key finding of our study. These are the contributors to the policy development of urban health policy in Nepal. For example, there was a growing international recognition and prioritization for urban health matters. For example, Dhaka International Conference declarations, Sustainable Development Goals 11, as well as the series of WHO and UN Habitat reports that highlighted the importance of urban health matters. Also in Nepal, the NGO were forefront in terms of demanding improving access, including health in slum areas, as well as there were a number of other key milestones that contributed to the urban policy development. For example, in 1999-2000, there was a Local Self-Government Act in Nepal and local self-regulation, which primarily brought the municipalities' local government forward, making responsible for delivery of services. Likewise, national health policy, highlighting the urban planned development in Nepal. Collaborative framework between the two ministries, Ministry of Health and Population and Ministry of Local Government, highlighted the strengthening local health governance. 2014 urban health policy also contributed, which emphasized on the urban health matters. Also, a small study conducted by HERD, a rapid assessment of the urban health clinics and the report, and the interim constitution itself. It's a big in the history of development in Nepal that it safeguards the health rights of citizens. And in 2010, there was a joint annual review between the health sector, among the health sector partners, particularly the Ministry of Health and Population and external development partners, which highlighted as one of the action points that formally identified this, that urban policy development and implementation plan is in essence. Following that, in 2013, the urban health policy was drafted, and finally in 2015, urban health policy was approved. Let me take you to the 5 key main factors that we found very essential to the development of the policy. One is promoting health as a development priority. I mean, it is important, particularly in low-income countries, putting health as a development priority, either at the federal level or at the subnational level, was very, very vital. And ensuring there is an appropriate legal framework in place in order to pursue the policy development process. Various policies and acts were really critical. They worked as a foundation for the urban health policy development. Identifying effective interface was also another critical, essential factor for the development of the urban health policy. Because we had unstable political environment, which was challenged in many ways, including the complex policy environment. Also, the collaborative multi-sectoral approach requires a smooth facilitation of the decision-making processes. So demonstrating that there has to be interface in between in order to make this process happen. Also, use of the evidence base during the policy development to make the case. The problem with the rigorous analysis of disaggregated data was vital. Also establishing a collaborative framework for clear differentiation. I mean, we brought multi-partners together on this process. So it was vital to have a collaborative framework in place which facilitates the opportunities to foster the dialogue among various ministries and stakeholders. Also, we identified 5 essential additional factors that would strengthen the development policy. One is understanding the financial, of course, resource matters a lot, and financial context, which basically impacted the prioritization and time allocated to develop the policy course. Also, different opinion in terms of who should finance the urban health care also dominated the policy environment development process. So understanding financial context is important. Developing resilience to the change in the government. And the policy process would greatly benefit if there is a clear step put forward in order to continue the process once it is started, especially important when there is a complex environment of the changes of various officials. Strengthening interface between the ministries is also another priority, and applying a program management approach to policy formulation with a clear defining roles and responsibility and ownership was important. Also, understanding the stakeholder, develop a corresponding engagement strategy is very vital. And the power dynamics and relationships between them, and explicit develop a corresponding strategy to engage the stakeholders. My final slide conclusion is the study identified 5 processes essential and then other 5 supportive, which are very important to consider while developing the multi-sectoral policy like urban health. And the lessons learned from this study will definitely help in Nepal developing multi-sectoral policy, as well as in other countries who are facing challenges of urbanization. Finally, I would like to acknowledge a number of partners, particular COMDIS HSD, which is a research program consortium, as well as the UK aid from the government of UK. However, all the views that I express here, along with other co-authors, are not necessarily reflecting the government of UK official policies. Thank you very much. Thank you for listening.
Yeah, thank you so much, Sushil, for that wonderful presentation on the processes for developing policy. So I ask again to the floor to please ask your questions. If you have any questions, don't forget that you can also type your questions in the live Q&A chat box. We can answer them as well if you don't want to ask verbally. So while we get questions, Sushil, I have a few responses to your presentation. So it's interesting, the processes you outlined, and they would apply almost anywhere. But the question I had was, to what extent do you think the type of overall governance structure affected the implementation, if I will use that word, of what you did to bring about those processes? In other words, how does the governance pattern, overall governance pattern, overall governance context enable or impede your ability to form those kind of processes that you noted were important for advancing the policy on urban health systems?
Thank you very much. That's really key question. When you develop multi-sectoral policy, which requires engagement of greater stakeholders, governance matters a lot. And in our case, the context where we started developing this multi-sectoral policy, which brings various urban stakeholders together in order to deliver the policy format. It was an issue at the beginning because where the health falls within the urban and rural area. Ministry of Health and Population largely responsible for the rural area, and municipalities were autonomous, they were independent, so health was part of the municipal authority within the municipality. So that created level of confusion in terms of who should provide the leadership, the policy framework leadership in development of the urban health policy. Because of that reason, the urban health agenda was left untouched for a long period of time. Even the policy aspects were silent because of the lack of the governance. However, with the realization, here I bring the evidence into account, presenting evidence in a way so the stakeholders could understand, and presenting evidence to inform the governance process of the policy formulation was an important part of the policy development process. So where we could see a collaborative leadership from Ministry of Local Development, Ministry of Finance, Ministry of Health, and Ministry of Urban Development. So that governance structure itself coordinated by Ministry of Health and Population, because these were largely dominated by health sector, because it was urban health policy. The barriers was not every, I mean, in terms of balancing the ownership of this process was an issue. If the Ministry of Finance does not take the ownership, then the policy does not get funded. So it was equally important to have them on board and get that level of ownership in terms of securing the resources for the policy implementation process. So that is where the priorities shifted and ownership a bit questioned during the process of development of policy. However, later on, the policy came out, the implementation rolled out, and we had this massive decentralization in health. Not only in health, but the overall country political decentralization, federalized context. We moved in from unitary government to 753 local governments who were supposed to implement the policy framework that has been developed at the federal level. So now we are seeing the implementation rollout moving ahead along with the notion of the policy, which was not there before when we had unitary mechanism. Over to you.
That's quite interesting. How dynamic or dynamism in terms of how the dynamism in terms of governance structures, governance processes can affect what we seem to have conceived within the health micro system of the overall health system. So you mentioned something else that kind of sparks another question in me. So you said one of the ways you were able to get through and succeed was presenting evidence to inform the process in a way that stakeholders could understand. I mean, I would think that that's a double tall order, given that urban health systems by default receive by default would not receive ready support compared to maybe rural health systems for the poor, and especially within LMIC settings. Can you shed a little more light on how, or the strategies that you use to present this evidence to stakeholders in a way they could understand, and how that actually gave results?
That's really another important question, and thank you for asking it. The evidence, when I say, first is we often say is urban is full of people with wealth and level of rich people reside in urban area, that particularly marks the urban poor, the urban disadvantaged population in the city. Historically, like in other LMICs, Nepal also kept on presenting comparison between urban and rural, but there was no disaggregation of urban. In certain proportion of the urban population who are really disadvantaged are really fall below the health status, falls below the rural poor as well. But because the notion, the way traditional thinking and the way evidence was generated from the past kept on masking the reality of the urban poor. In this backdrop, it was really, really difficult to generate evidence, to have to use existing evidence, because you did not have that much disaggregation. So what we did is we tried to unfold knowns and unknowns about urban disadvantaged populations. So knowns one side, unknowns, where the list of unknowns were quite a lot. And did we require to know this thing in order to tailor the health policy that benefits the urban poor? So we presented that whatever the data we had from National Demographic Health Survey, the routine health information management system, and the small piece of surveys, and we did a very rapid assessment of the public urban health clinic owned by the public sector. And situation was not really convincing for many people in order to, I mean, can we deliver health services from these clinics to the people where the basic standards are not met? So we quickly generated some evidence rather than waiting to undertake a big survey. We used the existing evidence and presented to the stakeholders, multiple stakeholders, and then made a case that evidence tells us, whatever available evidence we have, it clearly indicates that poor are not receiving the basic healthcare services in urban area. Because our clinic opening time, for example, they leave their house early in the morning at 7 in order to get their bread and butter, and come very late evening, but our health facility opens at 10 o'clock and closes at 2 o'clock. So no way convenient for that sort of information. Community voices we captured and presented to stakeholders, not one time, consistently several times, using appropriate platform as and when we got opportunity. So that was really convincing case. Then we made this urban health need for urban health policy, particularly focusing on urban poor, was readily well accepted by the stakeholders. And then we started talking about urban poor and rural poor. Otherwise, we were largely focusing, because predominantly we were 80% of the population residing in rural area, and the urban poor was marked under the rich and the richest. That evidence really changed the game here, but it took a long time. Over to you.
Interesting, and yeah, so it's interesting that you were able to stick to the process for however long it took for you to get and pierce into that barrier and get the evidence across. And it's really glad that, or heartwarming that we see a situation where evidence can actually inform policy, because it's usually not the case. As everybody will know, evidence is just one piece of what politicians or decision makers put together to make their decisions. So
can I just say one thing on that? I mean, we have experience in the past, and continuously we are practicing. If you present the locally tailored evidence that is generated from the local to the politician, and there is a high chances they will listen to your data, listen to your analysis. If you present international evidence or the national average to a municipal corporation, we found that politicians were least interested because they were not their voters. So I think it's very important that contextualization of the evidence and use of local evidence in order to inform the local stakeholders and policymakers is really, really important. Of course, it takes time. We all know that how the policies are born in LMIC's context. But building on this, we have greater opportunity if we really, all the time we say that we don't have disaggregated data, data is not enough, evidence is not enough. Yes, that's true, but whatever we have, better use of evidence in terms of informing policymakers is one way forward. Over to you.
Thank you so much. There's a lot to be unpacked in what you have said, which brings me to, I'll come back to you later, but I'll go right back to Ifeanyiwa's presentation. Hello, Ifeanyiwa, are you still there? Ifeanyiwa, can you hear me?
Yes, I am. I'm here.
Okay, great. So, Sushil, your presentation was great. So, Sushil also made some interesting comments, which I thought could apply to some of the things you said. So it's great that we are having these conversations. So my response to you will then be that, yeah, so given the diversity of stakeholders that you brought together in your own study, and given what they know, what's the likelihood in Nigeria that these findings can actually inform whatever policy would come out on reducing diseases burden among urban poor in Nigeria? I mean, what strategies can one possibly use to make sure that these research outputs don't go to waste?
So one of the strategies that we're targeting in using is from the evidence we have from the urban poor to see if there is a buy-in. We found that if studies on health-seeking behavior about the urban poor have consistently pointed out that one of the first points of access to health services is the patient medicine vendors in Nigeria. And we found that one strategy that could hit home is trying to see how we can incorporate the services of these informal service providers with the formal service provider through policies. We know it's not going to be easy, but constant advocacy and then finding ways that can boundaries for each of these sectors, because we know there are some services that these informal service providers cannot provide, okay? But if we're able to find boundaries for each of these sectors so that together they can provide the needed services that we require. Again, we know that the formal service providers, like we pointed out in are not adequate and not available. So by incorporating these informal service providers, we should be able to find a seamless way to allow them to also help and improve the health services provided in the country. So that's one of the things we plan to do.
Thank you so much. That's an interesting way to go about it. And it's actually very relevant because you need, like Sushil said, you need to work with what you have on ground and not what you wish you had in terms of data, in terms of personnel. So like they say, you have to work with what you have to get what you want. And I think as bad as it is, there are still a lot of things that can be useful to LMICs to improve their health without having to spend much, but that's the talk for another day. So I still have some questions for you, Ifeanyiwa. So we are talking about urban poor in Nigeria, and that word alone, I mean, urban poor, it strikes home as, yeah, so we are talking about them with respect to the health system, but we know that for health systems around to function very well to serve them, we are going to need to engage broader than the health systems. What I'm trying to infer is that for the urban poor, we are going to need to bring a lot of people to the table. We are going to need the Ministry of Finance, for example. We are going to need the health systems stakeholders, for example. We are going to need a lot. I mean, mention it in Nigeria. So you know everything that's, I mean, every ministry that has to do with determinant of health that will affect these people. So given what we know about fragmentation in Nigeria, how well do you think all the organs that need to be aligned and work together are actually working together? And if we are far from it, what do you think we can do to bring together everybody to the table so that we can achieve a reduction in disease burden for urban poor beyond what health systems can provide?
Okay, yeah.
just like we said in our conclusion, we said that for us to achieve improved health for the urban poor, there is need for multi-sectorial approach. And if you looked at our results, we found that to improve when we looked at the demographic characteristics, we identified the kind of living accommodations that is prevalent with the urban poor. And we said one of the strategies is that we need to proper urban planning in the areas they live. That means we need the Ministry of Urban Planning now to be able to do that for us. So we have already identified that we need a lot of ministries, not just Ministry of Health, to be able to do that. We need Ministry of Environment to come in, Ministry of Works, Ministry of Rural Electrification, because most of them live in areas that have little or no electricity. Of course, they have little or no source of water in those areas. So we believe the need that if through advocacy and then showing evidence of the implication of not having this necessary amenities for the urban poor and what it can do in the long run for our society. We believe that all these ministries can come together. We've already started working with them. We've already started distributing policy, distributing these issues to them so that they are already looking at it and they already have a feel of what is happening in these urban poor areas, the slums especially. And I believe that with constant bringing to the fore of this issue, definitely we'll get some policymakers that will begin to make our case in their ministries. So I think it's possible that we can achieve it somehow.
Thank you so much. I feel like just going on and on, but we have to pause at this stage so we can take the two remaining presentations. So I'll come back to both of you later if we have any questions. But for now, I would like us to move to the next presenter. So our next presenter will be Annie Wilkinson, and she will be talking about understanding urban health governance, lessons from informal settlements in Freetown. Yeah. So Dr. Annie Wilkinson is a research fellow of the Institute of Development Studies, and she studies on research fellow in the Institute of Development Studies. So I'll leave the floor for her to take her presentation now.
Hi, this is some work that's based on, this is work that we've done with the Sierra Leone Urban Research Centre with Abu Conte, so Sudi Augustina Selu and Joseph McCarthy, and it's on understanding health governance in Freetown. The question that we wanted to ask was what governs health in informal settlements in Sierra Leone, in particularly Freetown. And to do this, we did ethnographic fieldwork in 2 settlements. One, we did narrative interviews, we did participatory workshops, and we did governance diaries where we made repeated visits to the same household over the course of 6 months, going once a month. Quickly, we define governance as the political and institutional processes and power relations which shape how people and groups understand, organize, and act within complex social ecological systems. Recent frameworks for health system governance have elaborated on some of the key components and basically said that governance is about, there's multiple actors, which is different policymakers, providers, and people, multiple kinds of rules and norms. So operational rules, which are about the day-to-day, the rules influencing people's day-to-day decisions. Collective, which are the rules made and followed by people close to the ground, but collective kind of entities. And then constitutional rules, which tend to be those set by government or large government-like organizations. These frameworks also emphasize that distance and scale is important. So for example, constitutional rules tend to be a little bit more remote or further away from the everyday operational ones. In these frameworks and in our research, what matters is the interplay between these people or actors and these rules. And our focus here is on rules in practice. And of course, within that, power and context matter and are important. So the context here is informal settlements, and this is a huge development challenge with approximately 1 billion people living in informal settlements or slums, mostly in the global south. These are places that they tend to be classified as informal due to a combination of lack of formal recognition on the part of the government, absence of secure tenure for residents, inadequacies in the provision of infrastructure and services, overcrowded and substandard dwellings, and location on land which is not really suitable for occupation. So these were the two settlements that we worked in, CKG and Moiba, and as you can see, they look quite different. And one of the things we wanted to explore was differences within settlements, contesting the idea that they're all the same, contesting the idea that cities are kind of uniform governing units. Moiba on the left was originally settled, was originally outside of Freetown's boundaries, and so the land ownership was different there. And so original settlers owned the land by the traditional manner, so they cleared it for farming. But then the settlement grew with the creation of a government mine, which is now shut down, but people still mine there informally. Some of the settlers have now converted, the downhill original settlers converted their tenure to officially government recognised freehold, but many people living up in the steep hills haven't, and they're newer residents and they're seen as informal. So CKG on the right is a dense coastal settlement in central Freetown. It's growing because people are actually physically creating more land by building out of the coast using rubbish in a process called banking. And this is something that Freetown City Council deemed to be illegal. The first thing to say is the constitutional rule framework in Sierra Leone is complex. The council is supposed to have responsibility for the city's health and especially sanitation and waste, but in reality they do not have power or resources to do this. Decentralization after the Civil War didn't fully devolve those powers, and they still depend on their budget from central government, which when central government and Freetown City Council, different political parties, that can be not always forthcoming. So in 2019, however, the mayor on the left and the president on the right in that picture did come together to launch the Transform Freetown agenda and promised to decentralise and work together on that. And then the mayor also has launched a new tax initiative to try to raise some urgently needed funds for the council so they could have some fiscal independence. However, this process is now stalled because the central government have halted the payments and claimed that due process wasn't followed. Meanwhile, city council staff salary hasn't been paid for months, and so you have practices such as the sanitary officers continuing their normal practices of enforcing kind of long outdated public health regulations, so going around basically essentially kind of issuing sporadic fines, often on poorer residents for these regulations that date back to the 1960s. I want to just focus on two stories about collective action and the governance structures in the two different settlements. So first of all, in CKG, waste is a problem due to the proximity to the dump site and also being at the bottom of Freetown's hills. They're prone to flooding and vector-borne diseases. But they've got a relatively coherent community structure with chiefs and the ward councillors and youth coming together to kind of come up with cleaning initiatives, to have bylaws against littering. And they say their main challenge is actually that rubbish coming from outside, so people depositing it at night, or actually Freetown City Council depositing the city's waste, but doing it carelessly in the places that the community has cleaned. However, Freetown City Council argue that the community shouldn't be there to begin with because they're reclaiming this land from the sea. The residents then point out, well, the community still collect and receive the taxes from them, so they must be legitimate in some way. And they've now tried to kind of come to an agreement that they won't do any further banking, and that's a community kind of imposed rule as well. In Moiba, in contrast, the community is very large and actually has many different kind of settlements within it. The people living at the bottom of the hill, as I said, often have formal tenure, and they also have better services. They have a health clinic, and they view the uphill residents as being kind of troublesome, and the uphill residents have now said that they needed to have a health clinic because they don't have access to it any close by. And so that would have entailed them identifying the land, building the structure themselves, and then asking the Ministry of Health to supply a nurse. However, divisions within the community have meant that they haven't actually been able to kind of collectively agree on this and to organise and collect resources to do it, so it hasn't happened. Quickly, the conclusions are these are ongoing and fluid governance arrangements. So it's hard to kind of make conclusions about them, but the feature of them is that they blend traditional, formal and informal authority and status, and which often links to land ownership. The two settlements, it's very different. The rules cannot be taken for granted in either settlement. And of course, that shows how informal settlements are really diverse. Overall, this research, I think, has also revealed that there's important urban elements of the urban context and urban dimensions that are important to health system governance in cities. So in Freetown, what we observed backs up what has been found in other, noted about other African cities, which is that modern city boundaries and municipal jurisdictions often don't align. Decentralization is often incomplete and has been a major source of contention. City governments rarely have fiscal authority and struggle to get it. Legacies of colonialism shape cityscapes, but also governance structures. And then the management of ownership of land is often really unclear and outside of the city control. And then finally, informality is pervasive, but not uniform. And we need to understand more about how people use it strategically and who gains and who loses from it. Thank you very much.
Yeah, so thank you so much for the presentation. I would like to once again remind the House that you can write your questions in case you don't want to ask them directly to the presenters. You can write them, use the live Q&A box. So before we move to the next presentation, I would like to take some of the questions we already have. So Babatunde Balogun asked this question, and I will just read it out. He says, urban poor is a peculiar group globally, and they tend to turn out worse health indices compared to rural dwellers. Now, a major challenge is access to wholesome health information that ensures the people engage in appropriate sanitary and nutritional practices. So the question now is, how can health systems be designed to address health communication deficits? That's a very important question, because an often overlooked and understated disadvantage that urban poor have is that they usually don't have the information we think they do have. And the oversight is because we tend to just think they are living within urban setting, and by default they have questions. So this is quite a very important question to ask. And I will ask it to our panelists. Let me start with Sushil. What's your take on how we can improve? Yeah, I know you discussed how to provide information to policymakers, but right now this question is saying that we need to also provide adequate information to the urban poor themselves. Sushil, how do you think we can go about this?
Thank you for the question. This is really important one. Access to health-related information, particularly among urban poor, has been an issue, especially in low-middle-income country setting. We need to understand that within the urban area, if you look at the system, there are systems within the urban health, and the plurality of the providers makes this more complex, where to seek information, in particular the service availability information. What are the services available for whom and when and where? Those kind of information are not readily, effectively communicated by the urban health systems. Because identifying who are the urban poor and having appropriate channel of communication for to them is an issue. Although we have technologies, but reaching out with the appropriate information to urban poor has been a challenge in many LMIC's contexts. I think important thing is engaging them in the process of engaging them in the system is itself important part. Where I mean, we have experience of engaging, we call it community engagement in practice. So we reach out to the people, try to understand what do they know or what they don't know regarding the basic health related information, so they can access to healthcare when they need it. In the meantime, it's not just providing the information. The second thing is making the services readily available for these people, which is a difficult part, reaching out to the urban poor. What we did in our context to understand this better and reach out to the urban poor is engaging them in the process of formulating the communication strategies for the urban poor. So this is where the urban poor settlements and the communities we identified, we reached out to them with a very rapid assessment. What kind of information need do they have? And then what kind of channel they use in order to obtain the information. So many of them, they used the routine gatekeeper functions. So we identified the gatekeepers in order to reach out with them with the appropriate information. So that somehow enabled us to create this channel of information for the urban poor, so they can readily seek when they need it. The second part important is the community mapping. So in urban area, it's very heterogeneous. I mean, here you have a big house, big malls, but next to the mall, there is urban poor, which are completely hidden. So how do you reach out to them with the community mapping process? So you identify where they are located and what their needs are. We use this community mapping process by engaging the local health facility management committee of the municipal council in order to reach out to them with the volunteers. So there are a good number of, in particular in Nepal, the community health systems is so well organized in urban area, but not up to the mark in the rural area, but not up to the mark in the urban area, because people come from different part of the city, different culture, the level of diversity in terms of language and culture and various things. Basically does not help you to have greater community participation. But we tried that through the community gatekeeping functions and social mapping exercise in order to reach out to these people with the right information when they need it. I stop here. Over to you.
Thank you so much. I mean, insightful work you're doing there. Just still on that question to Ifeanyiwa, Nigeria is more, I think it's a bigger country, and I think has a lot more urban poor, I would imagine. So my question to Ifeanyiwa, what do you think the role of technology can be in terms of providing adequate communication to the urban poor? Can technology help bridge that gap?
So I'm wondering whether technology will be the adequate item to use to bridge that gap, considering that most of them might not really be technology savvy. But then it could still bridge that gap, but I'm just thinking whether it will. What we're thinking is that, like we had earlier identified, if we use the health system, because when in our results, we found that part of the drivers of their health problem is lack of access to information. And we have identified that one of the ways to strategies to address it was to educate them, health education. And even if we know, even if evidence has shown that the first point of contact for health services is the PMVs, if we can incorporate the PMVs and train them, the PMVs, to provide the services for us, because when a mother or a father comes in for a drug or something, and the PMV is trained enough to give that basic service, we might be able to start addressing the issue of lack of access to information. And we expect that also they will provide referrals to the patient, now to the formal health system. So I don't really know whether technology will provide it, but it doesn't stop us from providing it through that. It might do well for those with better education, but not for people with no education. That's what I think. But using our local ways of communication might do a better job in trying to educate the people. Thank you.
Thank you so much. Yeah, completely agree with you. Yeah, so running out of time, so I think we'll have to move to our last presenter now, who is Caitlin McBride. So Caitlin is a student from the University of California, and she will be talking to us. Her presentation will be on rural-urban disparities in health, using new geographical classifications to reevaluate distance and choice of health services in Malawi. Caitlin, the floor is yours.
My name is Caitlin McBride, and I'm a PhD student in the Department of Health Policy and Management at the Fielding School of Public Health. And the title of this study is Rural-Urban Disparities in Health, Using New Geographic Classifications to Reevaluate Distance and Choice of Health Services in Malawi. I'd also like to acknowledge the co-author of this paper, Dr. Karina Mouchereau, who is a professor in the Department of Health Policy and Management. In today's presentation, I will give a brief overview of the background and motivating rationale for the study. I'll then go into the study objective and study methods that we used. I'll then give you a detailed showing of the results, and then go into a little bit of the discussions and some of the limitations of the study. There's no universal definition for what defines an urban area, nor criteria for differentiating between rural and remote areas. Additionally, since there is no single urban-rural definition, countries apply their own criteria based on one or a combination of characteristics such as population density or presence of infrastructure. And these definitions can vary greatly, which limits cross-country national comparisons or multi-country analyses. This is particularly true even for standardized surveys like the demographic health surveys, as these countries adopt their own criteria. Additionally, use of the dichotomous urban-rural definition fails to capture important variations that may affect availability of health services. This may lead to misclassification of an urban residents. Few studies, for example, also evaluate differences between major metropolitan areas and secondary cities, as well as those living in more remote versus rural areas that are closer to cities. Grouping geographic areas too coarsely may cause misclassification areas in research, and may influence program and policy decisions about resource allocation. There exists a need to improve our understanding and classification of what urban and rural really means, and to move away from using these binary definitions. So how well can we measure and understand differences in health services access if we expand the binary definition? In this study, we wanted to answer the question, if we use a more granular definition, what new insights emerge about distance to and choice of primary, secondary, and tertiary health services? And what proportion of the population in Malawi would be reclassified under our new proposed categorization? So we examined the traditional binary rural definition to develop a new classification that can be adopted globally using Malawi as a case study. Geospatial methods were used in ArcGIS to link health facility data from the 2013-2014 Malawi Service Provision Assessment to census enumeration areas in Malawi. We developed a new 4-definition classification, differentiating between those in urban areas, between major metropolitan and urban township. Among rural, we use a global human footprint index, which includes information on population density, infrastructure, and land use and access, to determine whether households were in newly classified remote or rural areas. All those below the 25th percentile of the Global Human Footprint Index were classified as remote. We then, in ArcGIS, evaluated how these classifications affected households' distance to the nearest facility offering comprehensive primary, secondary, and tertiary care, as well as the choice of facilities people have within a 5 and 10 kilometer radius using road network distance. Finally, we used world pop data to estimate the total population that would be recategorized under this 4-category classification. We identified approximately 9,500 census enumeration areas in Malawi. The figure here, figure 1, shows the binary urban-rural definition of urban and rural census enumeration areas under the old classification. And under our new classification on figure 2, we highlight the 4 categories. And you'll see here, rural is in a lighter green, and remote, you can see, is pretty sizable in Malawi and takes up a good proportion of the country, and that's in the dark green. So here we present the results from evaluating the distance from each new 4-category classification to the nearest facility offering primary, secondary, and tertiary care. And we see that the average distance to comprehensive secondary level services for a newly classified remote household is 28 kilometers, which is considerably longer than the standard rural classification, which was approximately 22.8 kilometers. And we see here in distance to tertiary care that the range between distance to the nearest facility offering tertiary care significantly increases among newly classified households by an additional 4.1 kilometers comparing remote to new rural, and an additional 99.1 kilometers comparing urban to townships. This next slide shows us what this looks like when we extend the radius to 10 kilometers from each newly classified definition to see what types of choices of health services people have within a certain service area of health facilities. And so we see here that households in major metropolitan areas can access even more facilities offering comprehensive primary care, but most households still only had at most one facility of any type. Rural and remote households have nearly no choice of facilities providing comprehensive care. And only households located in these urban major metropolitan areas have any facility providing tertiary care within 10 kilometers. We then looked at what the proportion of the population would look like if we categorized them under these new four category classifications. Under our new 4-category definition, we would reclassify rural households and remote and move them over to the remote classification, as well as the urban townships, and reclassify them as well from the traditional urban definition. Under our new 4-category definition, we would reclassify nearly 3.8 million traditionally rural and urban defined individuals, nearly a quarter of Malawi's 2015 population. So by disaggregating rural households into classifications of rural and remote, we gain a much more informative view on distance to care. Consistent with prior studies, we find that health facilities and resources are concentrated in Malawi's 4 main cities. And by combining major metropolitan areas and urban townships under this, from the traditional urban classification, we lose a lot of information about whether households have choice when seeking healthcare. A few limitations to note here in this study is that our analysis does not compute travel time based on mode of transportation or account for seasonal effects and road conditions. We also do not evaluate the quality of service provision using the health facility data set, or whether facilities have the actual required resources to give care deliveries for a specific primary or secondary care service. We also do not look at other characterizations of remote that we could have used. For example, the global human settlement layer is another way you could evaluate heterogeneity in rural areas. Additionally, we do not have access to enumeration boundaries from the most recent 2018 Malawi census, which could provide more precise estimates of current household locations. Thank you very much.
So thank you so much, Caitlin, for that thorough piece of work on trying to unbundle newer classifications of rural and urban disparities in terms of health in Malawi. It's a very painstaking study, I must say, and congratulations on the good job. So I go back to our audience now, attendees. So just a reminder that if you have any more questions, you can just indicate by show of hand, or you type your questions in the live Q&A box. Yes, so we can continue. So while we await questions on Annie and Caitlin's presentation, I would like us to continue the discussion with Sushil and Ifenywa. Sushil, Ifenywa had opined that technology may not be as useful as we might imagine in terms of bridging communication gap that exists between urban poor and other categorizations. What is your experience and what is your take in terms of Nepal?
Thank you very much. I mean, we cannot deny the increasing use of technologies, regardless of what segment of the population. There are technologies which are reaching out to the people, and they started using it. Definitely, we should be capitalizing the availability of the technology in order to reach out to the people that we want to reach, particularly the urban poor in this case. First, we need to know that what level of urban poor actually use these modern technologies in order to communicate first. a brief understanding on that will help us to formulate our strategy. However, I don't want to rest only on the technological aspects. There are systemic issues. Technological product could be there, but how the system actually uses that product in order to benefit, to maximize the benefit to reach out to people with the right type of information is very important. So we are, I mean, in our case, we are at trying to understand the technologies, how far it has been used by particularly the urban disadvantaged population. The second important is to create enabling environment within the urban health system in order to use those technologies for the urban poor, which is not an easy task really. You need to really change the system thinking in order to understand what are the communication needs for these people in first place, and what are the means of reaching them with the appropriate level of information in given context. So I'm a strong believer of the local context that we are in. In the given diversity that we have in urban area, you cannot simply lump all the urban poor into one basket. They are different. For example, you can have different sort of strategy to reach out the economic migrants who have come from outside from rural area to urban area in order to generate some economic potentials. And they vary in terms of different, their classification is different. Entirely daily wages earner and a person who works in a decent service, a decent office facility. They also migrate, but the categories are different. So you need to tailor to different groups and their needs, as well as their means of communication engagement. So this is unfortunate in urban area. We don't have a good representation you won't find for the urban poor, because there are different small pockets where the urban poor are hidden in urban areas. Reaching out to them with the technology is one thing, but the engaging community, again, I come back to the global context, engaging community, identifying who are they, where they live, what is their health needs, and then tailoring our strategy and redesigning this system for communication. In our context, health communication is relatively poor, because we are much more provider-dominated health system that we operate in LMICs. The patient-centeredness is kind of a lack. The patient-centeredness, unless we change the system to really consider the patient-centeredness, either in service delivery or in the information communication, then we whatever effort we put, it won't really bring the fruitful result.
Thank you so much, Sushil. Thank you so much, everyone. I'm just going to quickly provide my final reflection because we are almost out of time. It's been a very engaging session and one I thoroughly enjoyed. So briefly, my reflections are that no matter what we do, we should always be try to use evidence to inform the process in such a way that stakeholders can understand, because this is very, very key. We have to make them want to look at evidence, even though we all agree it's not the only thing they consider. But the more evidence they use, the better. And we have to do our best to make sure they use the evidence. The second major point for me is that information is not complete if we don't bridge the gap with the people we are targeting, which is the urban poor. So we have to do everything to make sure urban poor are also well informed. And we debated different ways that technology can either contribute or hinder this way, but technology definitely has a point. Another great point we made was that context is everything. Context is important. Even as much as we call them urban poor, they are not the same everywhere. So we need to also be mindful of that in trying to design and implementing our intervention. And last for me is what Ifeanyiwa said about sustained advocacy. And we also saw that example in Nepal, where it took lots and different periods and different changes in urban governance to achieve the aims. So I just want to thank you everyone for coming. It's been a wonderful and engaging session. Bye.
Thank you, everyone. Bye.